All right, thank you so much. It's a pleasure to be here. So I'm Israel Enriquez, and I'll be happy to start this presentation. So we're talking about atrial fibrillation today. Financial disclosures, unfortunately I don't have any. So we're talking about the pillars of atrial fibrillation, and this is from the 2023 update guideline, and basically we're going to go through these and then try to kind of deep dive into the physiology and pathology of atrial fibrillation. So the guidelines will be updated regularly. When I started fellowship, they had a set of guidelines, and by the time I finished, there was a new set that they had made. And so I was like, okay. But one thing that will never change, or not change very quickly anyway, is the physiology and the basis for the disease. So we're going to kind of walk through these pillars, assessing stroke risk, symptom management, and then we're going to treat risk factors, which is the main thing, which is kind of at the bottom. So they use this acronym head to toes. So heart failure, lack of exercise, hypertension, diabetes, tobacco, obesity, ethanol, and sleep disordered breathing. All these are, risk factors for atrial fibrillation. So in general, this is kind of the experience in internal medicine, right? A patient has AFib, we consult cardiology, and then we've taken a poll, what happens afterwards, right? Do we care? No. And then some, we say we care, but we're in the yellow, okay? So after we consult cardiology, what happens? So we'll try to talk to what we do on our end. So what is atrial fibrillation? We'll start off with definitions. So this is from the ACC, the 2023 guideline. It's a supraventricular tachycardia characterized by uncoordinated atrial activation and consequent deterioration of atrial mechanical function. So there's basically this, supraventricular arrhythmia that is giving us. All right, so the prevalence, we'll talk about prevalence. So it was about 5 million, roughly 5.2 million in 2010, and it's expected to rise, a little over double to 12.1 million by 2030. So in your typical day, if you're averaging 20 patients a day, seeing patients that are age 65 or older, then there's a 94% chance that you will encounter at least one patient with atrial fibrillation. All right, so it will encounter you, whether you recognize it or not, it will be there. All right, and 20 patients a day, you'll have a 94% chance of seeing at least one patient. So it's quite common. All right, and these are just some figures. We see that the AFib detection, we've been increasing. Patients are living longer, so therefore we have more atrial fibrillation among us, which is not surprising. Everyone's also wearing these smart watches, right, thinking they have AFib, coming in and telling you that you have AFib on their watch, which may or may not be true. So diagnosing atrial fibrillation, so it's like quite an easy diagnosis. We can diagnose it by physical exam and ECG. All right, so unfortunately, for us, we've probably paid in the order of hundreds of thousands of dollars to acquire the skills to diagnose somebody. But for the insurance company, it's quite cheap. A physical exam and ECG, you can pretty much diagnose atrial fibrillation. So what is the hallmark finding on physical exam of atrial fibrillation? What is like the thing they keep telling us? In medical school, they kind of keep preaching this, right? What is it? Anyone want to venture a guess? Yeah, they keep saying irregular, right? Say the word irregular as many times as possible, and that's what they keep saying about atrial fibrillation. It's irregularly irregular. All right, so what does that really mean? You've got an irregular pulse, but what does this irregularly irregular come from? And in the words of one of my favorite colleagues, Dr. Delgado, all right, so what does it really mean? So the rhythm is quite irregular. There's no rhyme or reason to the pulse, but also if you remember back to medical school, your favorite friend, Dr. Frank Starling, right? Everybody loved the Starling curves, You'd memorize them the night before and then quickly forget them. But in that message was basically, the longer time that you have, before your contraction, the harder the heart's going to contract, right, within physiological limits. So this irregular pulse also has varying intensity of the pulse, and that really is the hallmark. So if you were to feel your pulse, hopefully you're all in sinus rhythm and it's quite regular. But if you're in atrial fibrillation, you'd feel this very erratic pulse, but the intensity would be changing beat to beat because of the varying R to R intervals. All right, so that is like the hallmark on physical examination. And then after the physical examination, we do classic ECG findings. So, we get to listen to the patient, look for, signs of maybe heart failure or thyroid disease. Maybe they're coming in with bulging eyes and a big goiter and telling you, Doc, I've got palpitations. You take a listen, you hear irregular pulse. The intensity of the pulse is changing, and they do an ECG, which is like our handshake. Somebody comes into the cardiology office, you say, oh, hello, welcome to the cardiology office, here's an EKG, right? So do an EKG. And then what do you find? And a lot of times you get an EKG like this, right, that's kind of smeared, and you're like, look at the baseline is kind of bad, and you see that the P waves are replaced by fibrillatory waves, and you have a narrow complex with irregular R to R. So that's kind of the hallmark of physical exam of ECG. And I kind of came up with this little acronym for the students, right, ROAST. So basically, if they don't know the criteria for the ECG, then I roast them. Not really, but it's something to remember. So it's rapid oscillations varying amplitude, shape, and timing. These are the characteristics of atrial fibrillation. All right, on ECG. So here's a little bit more clear picture of an ECG. So you can see it's narrow complex, so that means the QRS is less than 120 milliseconds. The R to R is irregular, and then if you look for atrial activity, you will find these small fibrillatory waves that vary in rapid oscillations, vary in amplitude, they vary in shape, and they vary in timing. All right, so that's the, after physical exam, you ECG, then you diagnose the patient with atrial fibrillation, and then we'll talk about, why and what. So classification of atrial fibrillation, we've thrown around different terms for a long time, but in the 2023 update, we've kind of basically tried to say, okay, what is atrial fibrillation? So they kind of made these different categories, 1, 2, 3, 4. 1 being at risk, and then 4 being permanent atrial fibrillation. So pre-AFib is kind of like patients that have risk. If they have other arrhythmias, like a lot of PACs, they have changes in the atrial anatomy. And then we can talk about these other kind of timeline definitions, persistent atrial fibrillation. So persistent atrial fibrillation is an AFib that's 7 days less from onset. And really what this came from was in the early literature, basically what cardiologists would do is they would cardiovert the patient and then say, I'll see a week in my office, right? That's usually what we tell the patients, Okay, come back in my office within a week, you do another ECG, patient's still in AFib. So they found that if you are still in atrial fibrillation a week later, it's a much more difficult patient to manage in the persistent atrial fibrillation. So less than 7 days, paroxysmal, greater than 7 days, persistent. And then if you have it, atrial fibrillation for greater than a year, we call that long-standing persistent AFib. And where does that year kind of guideline come? Is the AFib like doing a mental countdown and saying after a year, I'm going to be extra bad? And the year is basically, this is the time that it takes for permanent fibrosis to happen in the atria. So if you look at the MRIs of patients that have been in atrial fibrillation over a year, you'll see a lot of fibrosis in the atrium. So the electric changes are persistent after a week. So that's why we say, the patient has, persistent atrial fibrillation, and then really anatomical changes are going to be with you after a year, and that's where we do the kind of cutoff. And then you have the last stage of stage 4, which is permanent, where you're kind of given up and saying we'll keep the patient in atrial fibrillation. We'll just try to control the rate. We won't, attempt to do any more rhythm kind of controls. So that's permanent atrial fibrillation. All right. Definitions, which I talked about, the atrial fibrillation, clinical AFib, I do want to go over. So in all the studies, or the early studies especially, we defined AFib by the ECG. Now everyone has a monitor, right? Everyone, maybe at least 80% of the room is wearing a smartwatch, and it's alerting you to your every move, and telling you to stand up and check your text messages, and then, alerting you that you might be an AFib. And then a lot of devices are worn. We put in a lot of devices, pacemakers, loop recorders, and all these things. But if you look at the studies, most of the data we have is actually ECG-driven diagnosis of atrial fibrillation. So then you get to the what do we do with all these AFibs that we're finding, and how long is meaningful? And so we kind of classify those as like subclinical AFib. Sometimes they're not even symptomatic, but we detect them on device interrogation, things like this. So, what is really, a bad episode? Anything greater than 24 hours, definitely would be even asymptomatic. And then really even 10 minutes, you're probably starting to see some kind of changes in the atrium. AFib burden is very important. Obviously, the longer you're in atrial fibrillation, the more chance you have of the remodeling of the left atrium. And then we talk about, which we said, paroxysmal, persistent, long-standing, and permanent as those definitions that we've been using lately. Old definitions, chronic AFib, it really doesn't have a definition. It kind of varies in the literature, so we say don't really use that term anymore and try to replace it by something that's a little bit more precise. Valvular and non-valvular, this is a question comes up all the time. So in the classic literature, valvular AFib, it really means a patient with rheumatic mitral stenosis. It's a kind of a different kind of a patient. But they say in general, we use AFib in all kinds of valvular disease. You see patients with aortic stenosis, bioprosthetic valves, using anticoagulants, especially the NOACs, with no problem. So they've kind of abandoned this valvular and non-valvular in general. And then the other term is lone AFib, which I've seen in the literature, also kind of an abandoned term because it basically is not really defined well.